Hi everyone, welcome to our third seminar in the Health Terminology Standard Seminar Series. My name's Linda Bird. Most of you have met me, but for those who haven't, I'm an adjunct assistant professor here at the University of Victoria, an active implementer in healthcare interoperability standards, and the instructor of HIMP 597 course, which is hosting this HTIS seminar series. And by the way, HIMP 597 is the field project in health informatics. So welcome everyone. Before we get started, we'd first like to acknowledge and respect the Lekwungen peoples on whose traditional territory the university stands, and the Songhees, Esquimalt and Wasanich peoples whose historical relationships with the land continues to this day. So, as I said, today's the third seminar in the Health Terminology Standards series, and the topic for today is Connect Care, Building a Better Health Record in Alberta Health Services. But first, just a quick look at the rest of the seminar series. Over the next 2 weeks, Derek Ritz will join us to explore computable care guidelines on July 2nd and the Buildable Digital Health Blueprint Toolkit on July the 9th. And just a quick reminder that applications for our next intake of the Certificate in Health Terminology and Interoperability Standards closes soon on July 15th. This is a one-year part-time program with 4 graduate level courses, including this one, which are done through weekly online evening classes, plus the virtual workshop. This is the only terminology standards program in Canada that's accredited by CHIMA, the Canadian College of Health Information Management, to become a certified terminology standards specialist in Canada. So if you'd like to join our September 2024 intake, the deadline is July 15th. Please submit your application. And to find out more, you can either super quickly scan the QR code or visit the school's website and look for certificates. And so today I'm very pleased to introduce you to Debbie Pinter from Alberta Health Services. Debbie is a dedicated nurse, experienced leader, and a clinical informatics professional with over 25 years' experience in supporting quality care through the delivery and implementation of clinical and corporate systems. Debbie holds a nursing, zoology, and master's degree in adult continuing education with a focus on leadership and development from the University of Calgary. Debbie's experience in large-scale transformation initiatives enables her to support organisations with change, engagement, training, and adoption of healthcare technologies. Debbie's most current role within Alberta Health Services is Clinical Operations Informatics Officer, COIO, at Alberta Health Services. The COIO is accountable for the Connect Care clinical operations team that leads the operations aspects of Connect Care. This focuses on the clinical design, workflow, engagement, adoption, and training. As CIO, it's a mouthful, she engages with business and clinical operations to present recommended actions to facilitate ongoing Connect Care optimization and user satisfaction. She is enthusiastic and passionate about incorporating evidence-informed decision support and safety constructs into Connect Care and also supporting clinicians to use technology to promote quality care and positive patient outcomes. That's what we need, more enthusiastic and passionate people in health IT. So well done, Debbie. Debbie is a native Calgarian who lives with her husband and 3 children, Talise, Keegan and Callum. Spending time with her family is most important to her, and she loves to garden, do yoga and ski. So we all feel like we know Debbie a little bit better now. And with that, I will pass the screen over to you, Debbie. Thank you so much. The screen is yours.
Well, thank you. That was a lovely introduction. All right, so let me share. To presentation.
We see your notes right now.
There you go. How's that?
Perfect. Great.
Yeah.
Thanks.
Well, thank you, everyone. It's I'm glad to be here. I've presented at this, with Linda for a few years now in this course. And so I wanted to give you an overview of Connect Care and get you starting to think about the things that may need to be in place before you can really start thinking about terminologies, how to use terminologies, and thinking about interoperability. So it's quite exciting here in Alberta in that we've had this Connect Care initiative. And so I know there's just a few of us. So why don't we make this an open discussion? I'll go through a few slides. If you have any questions, we can, discuss, answer questions, and really just get into some good dialogue. Because I think, with the small group that we've got here, we have the time to do that. All right, so I'm going to talk a bit about our Connect Care project. And okay, so talk a bit about our digital health strategy and what we needed to do to prepare us for Connect Care and even to get us into the future. Want to look at what Connect Care is and how big and broad it is, so that you have an understanding of an integrated system and what it means to be an integrated electronic health record. Talk a bit about our health system overview and how we had to think about things, not just from an inpatient, for example, perspective, but really had to broaden our perspective into all domains of care. We'll talk about clinical informatics and where we would see a lot of maybe terminologies or, interoperability conversations coming in from that clinical perspective. Look at some of our Connect Care work on clinical content standards and workflows, because that is the gold of a system. If that isn't done well, really the data out is not going to be the best. So you have to spend a lot of time in this space, thinking about this space prior to doing an electronic, or a health record project. And then just a few other considerations that we have found that are so important to keep moving your system forward. So the first around the digital health strategy. So this is something that we have crafted in the last 3 years to support Connect Care as we've been moving through this project and the work we're doing with our electronic health record here in Alberta Health Services. And it changes. I have to tell you, our thinking, we started this, signed the contract 2017, 2017. We started decision-making for this work around, in 2017, took 2 years to do a lot of that, develop our standards and our content. And then we moved into implementation. And, the decisions you made and the thinking you had 7 years ago, it's really different. And even when we started this digital health strategy, it's different now. And I look at this and I think, oh, what would we do different here? It's a 5 pillars approach to digital health. And we always are thinking about these things when we're thinking about the projects we do, the initiatives that we do, the systems that we bring into AHS, etc. So really thinking about our Alberta first. Let's put our citizens first and foremost and right at the center. What do we need to do with our technology to support them in their care, to support them in their health literacy, build that digitally connected community. And I'll get more into this, but it's how do we connect patients through to their care teams? There's a lot of work to do here. How do we work with patients to understand what their thoughts are about how the technology can help improve their health outcomes? We want to empower our people, which means our digital health teams, to do good work, stay satisfied in the roles that they're doing the critical work that's going to make the most meaningful, impact when it comes to health outcome. Data-driven decisions. We talk a lot about this: good data in, good data out. And some of my learnings in this space, and a lot of our learnings in AHS, I think, is, when we first started this, it's around the clinical content. Do you have the right order sets? Do you have the right content? What are you documenting? What are your drop-down menus in all of your documentation? What kind of data do you have in there for clinicians to use? But if you don't have the right workflows tagged with that, you're not going to ever get to good documentation in the system or good data out. And so some of our focus is really on workflow and adoption, and I'll speak to that. innovate upon our digital foundation. So over the last 7 years, we have a solid technology foundation, and I'll describe, and we can look at that as I go through these slides. And now we get to do exciting things. Now that you have a platform, it really does open it up for us to look at different technologies and how we might implement those. Our principles you'll see in there: minimum number of systems, most cost efficient, standards based, reduced variation, evidence informed, looking at data terminology, content and workflows, they all go together. And then really sustainable. Costs are so high. What we do has to be sustainable. Workflow decisions that we make now should really still apply 5 years out, even as care shifts. But it's hard to think that way because you don't know exactly where care will be 5 years out. Who is Connect Care? I guess, who will we reach? So at the end of the day, our population, and this is very specific to Alberta Health Services, you'll see our zone map there. We will have probably over 120,000 employees using the system, third-party contracted healthcare providers using the system. We will have our subsidiaries: Covenant, Care West, Capital Care, Alberta Precision Labs are all using it. We'll have physicians, nurses, nurse practitioners, students, like every healthcare, individual in AHS will be on the system. It's going to be across all of our acute care sites, our subacute, our continuing care, addictions and mental health, and many of our facilities, all of them will be using it. Does not touch upon organizations that are outside AHS at this point in time. So we don't have a lot of primary care. That we do have a footprint of primary care, but it's not far reaching into the primary care space. And we don't have any contracted continuing care facilities or private continuing care facilities. So that is our scope. Practice areas. So we cover the continuum. We are in acute, inpatient, and ambulatory spaces. We are in continuing care and seniors. We're in primary care. We are in home care now. We're in corrections. So we span the entire continuum from a practice perspective. We focus on foundational technologies and tools. We have a clinical informatics department that I'll go into in a little bit more detail. And in the foundational technology and tools, we integrate with many of our clinical engineering products. So, our cardiac monitors, ECGs, machines, full integration with DI lab, pharmacy, all of that. We use end user devices, rovers, phones, iPads, laptops, and I'll show you some slides on our Wi-Fi initiative that we did. We touch on supply management, telehealth, pretty much the whole spectrum of care. We have many different groups, as I've kind of talked. We have registries, we have reporting and analytics relationships with our Diner group, data and analytics groups. We integrate with drug databases, health records. There's a lot of stuff in here. And then the Epic, we pretty much have the full suite of Epic that we can use or within legislation are allowed to use, and we use it. That's really our scope there. This is our project, and you might see on my screen prior to sharing, we looking forward to launch 9, or we are launch 9. So we are done. So we started in 2017 with all of our decision making and our standards. 2019, November 3rd was our very first launch. And now November 2nd in 2024, 5 years later, we are wrapping up our 9th launch. And so all of these groups have come on, and we'll get into a lot of detail, but we do it every 6 months. It's a very exciting time and a lot of fun when we do launches. And maybe just any questions before I move on for the group, and then I can get into more specifics on the Connect Care piece. All right, so Connect Care, what is it? So we started this, we had a lot of disparate systems, and it's hard, right, to get interoperability with too many electronic health records, with you know, too many systems. I think at one point we had over 1,200 clinical applications for various reasons here and there, probably even more. If you had a chat with our CIO, I'm probably underestimating the number that we had. So we did a business case to bring Connect Care in, and to say, you know what, we're gonna have some value if we move to an integrated platform, versus having a best of breed you know, system in that way. And so we kind of bucketed into 5 different areas where there's going to be value to Albertans, value to healthcare providers, value to the organization, Alberta Health Services at that time, and now, as you know, Alberta is going to be 4 organizations. So it's value to the 4 organizations, it's value to the healthcare system overall, and what's our total value when we start to think of quality of care and costs. And so really better access for Albertans to their health information, better experience when they can immediately log into their portal and see their visit, see their, you know, lab, DI information, and they can be more involved with their care. They can actually message with their care team now in ambulatory clinics. It's, you know, it's really quite cool. For healthcare providers, same thing. Everywhere they go, it's the same tool that they use. If they work in, you know, the primary care space and it's on Connect Care, it's the same as an ambulatory clinic, as a specialist in AHS and or an inpatient environment. And we can make processes more efficient for clinicians in that they're using the same workflows anywhere in the inpatient space. The information can cross easily into other spaces. And so we're working through that. From an organization, you know, we can look at bed and capacity management initiatives. Our information is more secure globally as an organization. We improve transitions between departments, and we can use clinical best practice and share clinical best practice amongst many specialties. From a healthcare perspective, you know, it's consistent information. We can feed good data up to our government for decision making, and we can, you know, look at research and use the information within the system to support research better than we could in the past. And then overall costs are down with the system. It improves quality of care in that we can measure some real important metrics across the continuum, you know, and across all our zones and say our inpatient environments. Maybe an example of that is our incidence of pressure injury, you know, pressure sore injury, right? So we want to be able to measure these things. Accreditation Canada might be another thing. We can actually look at our accred across multiple units and see what's going on for our metrics. Before and after the implementation, this kind of just describes where we were at and where we are now. Level of automation, we were probably at a HIMSS level between 1 and 3 with our varying systems. We at launch 1 have progressed to a HIMSS level 6 for 139,000 users who use the system. We have 150,000 devices that we've been able to deploy to support access to computers so that frontline staff can quickly document. It's efficient, it's built into their workflows, it's available in the rooms that they work, etc. Whereas before, you know, it wasn't a consistent approach to computers and devices. Our Wi-Fi, so we had 10% of our sites had Wi-Fi, and now 100% of our sites have Wi-Fi across all of our areas that we are networked, 26,000 different network access points. Standardization, we had little standardization between our electronic health records, which really made our data and analytics groups' efforts to try and look at the data in a consistent way almost next to impossible. But now we have standardized 5,000 standardized workflows. We have content decisions that we had to make for care delivery in all areas that we have Epic implementation implemented. which allows for the data. It also allows you to put evidence-informed information that everyone can use in the same way. Training now, that is something that it does take a lot more to train, but there's a lot more technology. You know, HIMSS level 1 to a HIMSS level 6. You know, it's more than a paper chart. So our training is delivered to multiple employees per year and students. There is a lot for us to think, though, as we move through this integrated journey around what are the barriers. And we hit a lot of these, and we still have a lot of these. If we think of Alberta as a whole, we still have inconsistent clinical standards and technical standards across Alberta. When we start to think about primary care and maybe other private companies who deliver healthcare to Albertans. So something we work with government on, health information legislation does not, and yet hasn't caught up, hasn't moved from the paper system and or from the repository where you pull information in for everyone to see. We need to move into an integrated record. It creates different requirements for legislation. So we're working with government on what does it look like to update our legislation, even from an affiliate model to a shared record model. Clinical practices and preferences. For the most part, we've achieved standardization, but it's still really difficult to understand where are your gold nuggets. What if we try and look for what's the gold nugget in the system? Who's doing things really well, which leads to their practice may be different than standard, or they may add something in. And what is the preference for care there? Because obviously, you know, we want to look for who's doing it really well. You can think about COPD, heart failure treatments, hip and knee surgeries. Are we seeing any areas that maybe aren't doing well and or doing well? And we haven't achieved consensus on anything. It's an area for us to learn. Number of independent endpoints. Again, we still don't have everything integrated. There's a lot to think about. I'll talk a bit about that. We don't have common registries for everything. We still struggle patient, provider, and location registries. And then interprovincial sharing agreements. You know, who would have thought about this? But we have, use an example, Reno, you know, hemodialysis clinics that sit at the Lloyd-Minster border. And so it's in the clinic's on the Alberta side, but then there's Saskatchewan physicians who practice and they take care of patients, but it has to be different workflows because we don't have sharing agreements. Again, that support, you know, that are moving away from an affiliate model to a, you know, to a way that we can practice and use the technology together for the best patient outcome. So some things to think about, and you know, all of this hits. How do you look at terminologies? How do you think about your projects? You know, all of it can impact the way we strike up work and do work in the future. And maybe I'll just check any. I'm not checking the chat, Linda. So if there's anything in the chat, just let me know. And see if there's any questions.
I have a question. This is Robin, and I can't find my hand, put my hand up. So sorry about this.
Yeah.
So, hi. So I am not a student. So you need to stop me if I'm not, if I'm
Okay.
being, okay. So I have a background in health information and nursing and health policy, have been in the HIF program and in the public admin program. Work with Dennis Lee. So that is, know Dennis Lee really well. And we've got a deep interest in terminology and have had a challenging time trying to implement or to support implementation of terminologies in a way that maintains what we would say the integrity of the terminology as it's implemented. So my question is, you know, you brought all the data together and I know this is a huge question. I'll just table it. Then maybe if you could think about this as you're going through, there's how much, as you brought the data together and the information together and all of these systems together, and I know you said you used Epic as your core provider, but you have all of these feeders coming into Epic as well, and you have feeders going out as well, and you've got old data and new data and interfaces, et cetera. How much, and then also Epic and IMO are really tight. So and IMO has sort of a map everything to everything type of approach. How much did you rely on mapping? How much do you rely on terminology at, the coalface, so at the clinical interface? Is that a challenge that you're still working through? How do you think about that? And then also then as you brought all the data together, how did you assess the impact on your data quality? So that's sort of that's what I'll stop there.
Oh, that's such a
And
great question. And I feel we could probably even draw upon Debbie's experience too, the other Debbie Onis here. So, when we started this, you got to look at what's the front end, what is the clinical user doing with the system, and it's really their language is not a terminology, right? Nurses, docs, allied health professionals, they don't think in a terminology. They think around that clinical friendly documentation standard, right? And the terms that they might have learned in their university courses. Doctors think in notes, right? They don't think in data. They do a lot of progress notes. So when we were designing the system, we had a lot of conversations around what is the language that we present or that user interface to the clinicians for their documentation. We did use Epic's foundation, and so Epic does come with a foundation when you think about, systems assessment for nurses. They come with that language, and we adopted that. And so it doesn't align, with our nursing terminologies. It may not align with, lab length. There wasn't a lot of alignment, I don't think, from that front end perspective, that just because of the way that we adopted the Epic pieces for that. Now, at the back end, though, there was a lot of thinking done around the terminologies department that lives within our health information program. And so, not my full area of expertise, but when we were doing work early on with clinical content and standards, we did some mapping. And we would map to the languages or the terminologies that HIM had adopted for the organization, SNOMED, for example. And so I think that work went on earlier. I've been separated a while now. I'm not sure exactly where they're at. And then the data, interesting that, again, we're fortunate we have an integrated system, but we still have, for example, multiple DI providers that do x-rays and diagnostics that all file into Netcare. And how they link and share language is probably very different, right? And so a patient could maybe get something done at Mayfair, but then they go to the Avenida Diagnostic Center, and again, it's not the same. And so we do have, I would suspect, if they're doing any data and analytics on that type of stuff, maybe our Stafford Dean area, Dimer, they might be using terminologies to help with that. I don't know, Debbie, would you be willing to help or assist in any of the answering of that question?
Yeah, I'm always open to the conversation. It's been a really big learning curve. So Robin, I actually happen to be the director for clinical terminologies at AHS. So
yeah.
So yeah, this is my world. This is what I work with. And yes, Epic IMO relationship. I actually laughed out loud when you made your comment about how IMO works. I think the biggest thing that I would say that we've learned out of this is you have to take a step forward, and sometimes that step is maybe not your favorite, right? And it's not always your end goal, but you have to start somewhere. And so some of these vendor relationships, we have to take advantage of them. And it's better than nothing. So we really can, I think, come together, especially in Canada. We have a lot of organizations here that are using kind of the same combination as us. kind of push the agenda forward, right? And to say terminologies really do need to kind of take a bit of a forefront. And we, you know, I guess need to not get pushed around by our vendors as much anymore. So lots of education and understanding what the purpose of terminologies are. I think that that's been a huge eye opener. I think we had a lot of, you know, thoughts about how classifications and coding and terminologies would work together. And we've, you know, we've since learned. So it's a big road, right?
Yeah. I agree with that. And this is, and I'll stop there, but this is sort of the area that have deep interest in, and I would say the work that we've done has not been a success. So it's a continuing, like we've been involved in a number of terminology type pieces, and in every case there's it's a hard push. It's a really hard push, and one that we sort of think is fundamental to what you actually want to achieve. But so thank you very much.
Yeah, it's a really good question. You know, and with an integrated system, it's less about interoperability amongst vendors, right? And between systems. So terminologies, I don't think, to Debbie's point, may not necessarily take a front path. But as we get into optimization, you know, I think there's lots of opportunity for us to do a rethink. And, you know, how do we reposition terminologies now that we're done this implementation and we've kind of gotten through this last couple of years? So for me, it's the beginning of the end, or really it's the starting line. And so I think there's opportunity to redefine what terminologies and the purposes going forward. Yeah, I like the way you said that, Debbie. So health system capabilities, then, you know, you got to kind of grapple, and this kind of is the core, right, of terminologies, right? Every one of these probably has a certain terminology that can situate itself behind it. But when we're thinking about front lines, clinical services, clinical operations, we really had to wrap our head around capabilities. So order management is a capability that is used in every space. And what does it look like to determine the language that we use, the decision supports that we put in the system? How do we build in the processes and the workflows around that, as an example, right? Order management, clinical documentation. We spent so much time thinking about documentation from an integrated perspective. So how do we move away? Epic is a very discipline-focused system. So the docs have their stuff, and the nurses have their stuff, and the allied health. AHS is on a team, you know, a care team path, not a disparate disciplines like we might have seen in the past. And so how do you redesign the system or the workflows best we can, given the limitations of Epic, you know, or the things that work really well in Epic, and move towards capability functionality. So each one of these, we probably spent hours thinking about, hundreds and hundreds of hours thinking about capabilities and how do you enable that across the health system? What are the standards that you would look to implement when we're going through this? And then again, a capability planning framework. It's one thing to think about a capability. It's another to say, how am I going to enable that in practice? And so then you have to overlay, you have your standards and you've got your clinical content and you've got, you know, you've got all of those pieces, but then the workflows and the business and the project and the models, right? All of those pieces need to come in if you're going to get good data out. And really, if you don't follow the workflows in the system, you don't get the data that you might expect to see, right? So this whole, you know, guiding principles, we spend a lot of time looking at capabilities. What's our value stream to closed loop medication administration? Let's just think, if you're thinking capabilities, what's the value stream? What's the safety principles? Are we going to make it better? Are we going to prevent harm, right? The e-safety side of this, preventing harm was paramount when we thought through these workflows. And how do we know we were successful? So how do we measure closed loop medication administration, our barcode scanning, our success with that? And what's the adoption of that workflow? Because again, if people aren't doing it, if they're kind of got all these workarounds and, you know, not following process, it's really hard to do any measurement around that. And getting to that data driven is important. This one, again, it blows my mind. You know, I thought I'd throw this in there because I think it's important, right? Interoperability, terminologies. We have, you know, we have Epic, but we also have many other systems that bolt into Epic or are interfaced into Epic. So, you know, 119 non-Epic systems. We have around 236 interfaces in production. And so a lot of these pieces, this all has to work together. You know, we get, you know, daily volumes just on the side there, you know, ADT, 258,000 ADT messages a day, lab results, 400,000 messages going to and from and around daily, right? Lab orders, 290,000 a day, and then med orders, 203, right? Like, so think about that. Not only what we're integrated, but think about the work that happens, the messages and the things that happens within this system every day, you know. I try not to think about it a lot. It can get overwhelming, but it's also very exciting, right? To pull this all together and to have a map to understand from the time the patient's admitted all the way to the time they're discharged. What does that look like? What do we feed our net care repository, which is our provincial repository that everybody looks at for patient information from different visits? You know, how do you even bill? This gets into the billing of all of this and then is linked into your financials, your payroll, your HR systems. So a lot of work happened here in the beginning. Maybe I'll stop there and see if you have any questions again. And I think, you know, to your last question around terminologies, Robin, you know, thinking about all of this, they got to underpin it, right? Yeah.
Well, and this is a really cool diagram. And I'm sorry, I don't want to I'll just chat away here for a second. This is a really cool diagram, and I think demonstrates the complexity of the terminology problems you're facing as well, because every one of those systems has their own sets of content. And somehow you have to manage all of that. And that's beyond the technology side. It's the language side. It's huge.
It's the language side. Yeah, like if you think about, I go back to DI. DI is always a good example to look at. Diagnostic imaging within Alberta Health Services. Their terminology for their DI procedures is called CEPOL, and it's a Alberta-based language, right? It's not, you know, from SNOMED or ICD-10 or anything like that. What a private organization might use is could be very different. I don't know, right? And the term, and so how do you bring it all together when Alberta Health wants to know the total number of procedures that were done in the province for, say, a chest X-ray, right? So like all of those things have to be thought through at some point. And we probably, you know, it's probably a barrier. We probably don't do it the greatest way or as well as we could be doing it, right? So I just want to shift gears a bit about clinical informatics. This kind of focuses on the front end of the system, right? Good data in, get good workflows, gets good data out. And so it all starts with our frontline providers using the system to do their documentation, to do the order management, to do those capabilities that we look at. And so we have a clinical informatics program in Alberta Health Services, just newly developed over the last year. We've been working on it. We work very closely with our IT teams, our CIO and our IT analysts who are really that experts in the configuration and the technical pieces of this. But we have a CMIO office and we have a COIO office. As I mentioned, I'm the COIO, and then I have a DI partner. who looks at prescribers. And so clinical informatics is that, I might even have a definition. There you go. Who are clinical informaticians and what do we do? So we're clinically experienced staff, and we understand healthcare processes and technologies. We work directly with the clinicians in IT, and we make sure that the workflows and the design of the system is meeting the practice needs in the unit. And so it's really important that you have that interface, so that you can get the right front end, which can link to the, the back end and the good data out the back end. And so we spend a lot of time thinking about how clinicians will adopt the system, how they will use the system, are they adopting the system, and what are the barriers for them right at the front line. We got a lot of work to do in optimization to make our system better, and I'll speak a bit to that going forward. So we have functions. So it's kind of a package, right? When you're looking at implementing a system and even continuing on with the use of the system, you got to think about the user experience. We train people once we design and build and move a system into prod. We train them and support them, and we do communications, and we're always reinforcing the system best practices. We will work to do an update and improve our clinical content and our workflows in the system, because we've been implementing now for 5 years, pretty much, like in this project for 7. What we did in launch 1 in 2019, it's been improved since then and may still need improvements. And so we're constantly thinking about the best way to do things in the system, which shifts your data out, shifts the language. We're deleting things out of drop-down menus. We're changing things. We're looking at documentation and we're pulling things out saying, oh, it's never been used in 5 years. Let's get rid of it, right? We're changing our alerts. It's going to constantly challenge, but like you guys who are going to use terminologies for your work, it's going to constantly challenge you because the environment is going to be constantly changing. So how do you think about that, right? We do the clinical standards and contents, and I'll talk a bit about that: safety, usability, efficiency, and then a lot of in-system reporting, right? We've never had the opportunity to give AHS view of some of our reporting and our analytics. And so this is really exciting. And we have never had the opportunity to give data back to a frontline clinician while they're at the bedside doing care so they can evaluate their practice. And so to me, that's kind of really exciting. Examples of clinical informatics and downstream benefits. These are pretty straightforward examples, and you'll see a lot of this stuff, but really we have our clinical informatics. When we're thinking about flow through in the emergency department, we're thinking about how can the system be structured, or the documentation or the workflows be structured so that we can move patients through the system as the most efficient that we can, right? Because we want to free up beds for the next patient that's coming in. How can we give dashboards for management to do planning? All of those pieces. We work really well in AHS together with the team. You have your frontline clinicians and your managers and everybody who's in emergency departments. You have your informatics team who does a lot of translation, interpretation, brings that clinical lens, and then you have your IT teams who are building. And then, of course, we've got other teams. We've got our data teams. There's more people but really, like for informatics, we have an intermediate team that's working with clinicians and IT to bring it all together. And so the emergency department's a good example of that. We've designed COPD. We have order sets for the treatment of pneumonia. We're working very closely to always make sure in those high volume, high impact, high cost diseases, chronic illnesses, that we're, constantly making sure that the system is up to date in those areas. And then accreditation standards. We get a lot of work in this space. We just had accreditation through, and, they're commenting on our electronic health record use. They're seeing things we haven't even seen before, and they're providing us feedback on, well, maybe it's not working that well here. We're doing really well there. And so it's really cool to see how we're partnering with different organizations to make a better product. In all of this, patients, the care that we give patients, if we're doing these sorts of activities and initiatives well, the care will be better. Hopefully we've shortened wait times, or we've done the best to help shorten wait times. We've improved the clinician use of the system, and we've given what we need to give to the organization so they can run the business better. So that's a little bit about our clinical informatics department. Any questions on that? Linda, are we okay for time?
Yeah, we've got plenty of time, so if there are
Okay.
any questions, feel free to ask them.
Yeah. All right, so clinical content standards and workflows. This is the front end. This is where we bucket things, again, capabilities, right? Person management, which is the management of Alberta citizens' healthcare information, how they access that information, how they use that information with their care team. Encounter management is how we admit, discharge, transfer people within our system and throughout the systems. Med management is around medications and orders, and results are how we place those orders in the system, who places them, when they're placed, how they transfer from continue or care environment to the next care environment. Outcomes management is something, again, in the launch, we haven't focused a lot on outcomes management, and I'm hoping that we, as we start to move out of launches and projects, we can start really thinking about what are the outcomes we want to see and how does the system help with those outcomes. And then health system management is around how do we help our organization run the most efficient that it can. And so we spent a lot of time in this space many years ago, thinking about this, developing frameworks, and looking at all of these pieces so we could get the best documentation approaches in the system for our frontline staff. Our goals was to reduce the burden and eliminate duplication. We wanted evidence-informed best practice. We wanted to, and we need to adhere to professional and regulatory requirements, which was something that, you didn't see a lot in the paper system, right? There was no auditing, there were no controls around that. Technology helps with that. There's a lot of decision supports we can incorporate, but you don't want to have alert fatigue. You don't want to overburden your frontline staff so that they don't do what they need to. We standardized documentation vocabulary. So I use vocabulary as the front end versus terminologies is, we didn't use terminologies, right, with the frontline providers when they're doing their care and their documentation. We standardized our scale scores and tools. This is something that was really important to AHS. So we did not want 12 different tools to assess pressure, ulcer, having a hard time with this word today, pressure, ulcer, injury. We did not want that sort of stuff. We didn't want to have 12 different ways to assess falls. We didn't want to have multiple frailty tools that our providers were using. We wanted to look at how do we narrow that down to a reasonable amount that was meaningful in the care settings. And so we've done that. We also wanted to ensure that we had the right intellectual property agreements with anybody who developed a tool or a scale or a score that didn't come with the Epic out of the box package. And so we have a lot on that piece. We have what's called core or enterprise standards that are used across disciplines. So for example, 75% of nursing documentation is used across the different specialties, right? So cancer control, inpatient, documentation in medicine and surgery, and other areas, pediatric documentation, it's based on enterprise set of standards or core, and then we layer specialty where we have gaps. And so we were able to really focus on a streamlined build by doing that approach. So for example, blood pressure, it's done the same across every care setting, right? We all learned it the same. The, systolic diastolic shall be documented the same. So that will be an example of an enterprise set of standards. And we focused on our program in AHS that really hones in on patient and family-centered care is called collaborative care. as much as possible, we focused on patient and family-centered care in the system. And so I think, going forward, when you're thinking about terminology projects, all of that, is it always have that patient first and foremost and front and center. And then you can really think about, well, why would we do this project? What is it involving? And what are we going to improve at the end of the day? This is just an example of governance. We need to set up governance and still need governance into the future around committees, core content. We really had to adhere to this. And we also get a lot of criticism on that. Well, I have to go to this governing committee and that governing committee, but it's for a purpose, because you don't, in a province that we have 120,000 users, you can't have everybody doing different things. And so we really had to do the governance pieces for this. Where we worked closely, I think, with terminologies would be the nursing content standards, these three groups. And these acronyms are big. Nursing Content Standards Practice Work Group, Allied Health Content Standards Practice Work Group, and our Physicians Content Standard Practice Work Group. We did a lot of mapping in the early days, from our vocabularies to our terminologies, with our terminology group. And we did a lot of our initial thinking around terminologies by using these groups to advance the work forward, and same with clinical documentation. So maybe, if you're thinking about advancing terminologies and the use of terminologies in projects forward, what governance committees do you have to support that? Who's your leadership, your leader who's going to champion the work, right? We were very successful because we have senior leaders who supported us in standing up these work groups. And so think about that, because leadership is so important in moving projects ahead. These groups have been meeting since 2018 and onwards. We, every one of them, last nursing group was this morning, our meeting. We've been meeting every Tuesday since 2018, or even earlier, 2017. That's 70 people in the meeting this morning. And so, that's another thing around, maybe there's working groups for terminologies, and, but in the beginning, we didn't have 78 people. We had maybe 5, 10, 15. So, you're going to grow the momentum is kind of where I'm going when you're thinking about governance and thinking about engagement and thinking about getting people excited about that. And then we have many partners we partner with. We could not have done our work without our e-safety. Our human factors was absolutely necessary. Our IT, our professional associations, our professional practice groups in Alberta Health Services, and our experts in clinical content and workflows from the front lines. So think about governance and think about how governance can help you to make your projects move ahead, because I think that might be an area to focus on. That was enterprise governance. This those two, and then specialty. Again, governance is just multi-layered. There's multiple teams. You got to think about all the different areas. So we have our core, and then specialty gets laid on top of it. What's different in the medicine space between cancer and cardiovascular, that we might need to change the standards, different order sets, right? Different treatment plans. Cancer is about research. They're about protocols, different drugs. So all of those layers have to be thought about when we're looking at this. And I think we pretty much had a specialty content group for every clinical specialty. Dentistry has one, for example. We just actually started a new one for Indigenous health. So that's very exciting, right? Thinking about some opportunity there to build an Indigenous health lens into our electronic health record. Just some pieces on clinical content. I love this stuff. I could probably go on forever, and Linda will know, Rob and I we can go on forever, and I didn't want to spend too much time getting into the nitty gritty, but we're paperless, right? Everything that was in a paper went into the system. We had no more binders. Like, we had binder burning parties when we launched, right? So that was fun. We have standardized and integrated ordering tools, decision supports, documentation, associated workflow for nursing allied health physicians, clerical, and our management staff where needed. And so everybody touches the system in some way. We have portering on the system, our environmental services is on the system, lab, DI, pharmacy. So standardized that. Documentation spans the continuum of care. I've talked a bit about that. We have the HTIS policy and procedures where needed to support our electronic health record. We tried not to do policies and procedures. We tried to build the standards into the system so that it was intuitively easy to follow. And then we have documentation norms published for the different health professionals because it was important to follow a norm when you're in the system. Just want a bit about clinical content. This is all going to shift. Everything's going to change with algorithmic intelligence or AI. And so I just wanted to touch on this a bit because I think it's going to shift. And, you know, from your perspectives, think about what is AI going to do when now I might be linked to the internet and I'm getting some information fed from me from there, or I'm getting information from you know, generative AI models, and that's mimicking notes, which is really not coded documentation at all, right? Like, so some of these things, think about, we have all of these types of, we call it the algorithm intelligence in our system, to a degree, where I think a lot of people, you're seeing, you know, the trend or the discussion is around the generative AI and the predictive analytics. And so there's a lot of work happening in this space. We're a little behind the scenes. But one of the things I thought about as I was talking to Linda earlier and thinking about this slide was, for nursing, we are doing a position paper to say, how do we situate nursing to get ready for generative AI? What are the tools? What are the norms? What are the principles, you know, that we need to put into place as this starts to explode? How does this impact terminologies? How does it impact interoperability? What is it that you're going to need to put into place when this goes crazy? And so, you know, I don't know, that might be an exciting research opportunity. Also think about, when we're thinking about this, you know, what we have learned is it's not just about the electronic health record, it's about all the technology that the staff use to do their job. And so think about the experience and creating end-to-end experiences, you know, so think about the nurse and the provider, where they're learning and how are they learning? Oh, wait a minute, they're using their iPhone to document into Epic, right? Or they're using the application within Epic on an iPhone to document how do we message with each other? Because it's not just necessarily within an electronic health record that do that. You know, what is the patient's? What is the virtual component? All of these pieces are coming together to say it's not just about your electronic health record, it's about all the technology that an individual may use in their day-to-day, and it gives them, you know, their experience. Are all of these technologies integrated? Not really, right? But it's really good to have an understanding of the bigger picture before you can hone in and understand how are they documenting? Is it the most efficient, you know, and what kind of documentation are they using in each tool? Some successes, and then I'll jump into other considerations. So I talked a bit about this, but we've incorporated evidence-informed best practice into Connect Care. We've reduced the burden. We think we reduced the burden. Talk a bit about this, but if not, you know, maybe we organized it a bit better. We try to avoid duplication. We believe we have. I think we have ways to go to improve on that, though. We've moved clinicians to accept standardized measures and incorporated variants where needed, acceptable variants where needed. We reinforce patient safety, and we created standardized data sets to support self-reflection of clinicians so that they can look at their health outcomes, and then also to look at health system planning and evaluation. Questions? Okay, quickly, I'll go into other considerations. Oh, it always is evolving. So how's that going to impact the back end, the front end? It's always changing, continuously improving. We're doing sprints where we're focusing in on optimization of efforts and events with our front lines. We're looking at organizational priorities, which change. One priority that could have been a priority last year is no longer a priority. We have upgrades and updates and patches and technology changes. We've got clinical integrity and system integrity work that we're doing always. You know, we might change our DI tests that we do in the province every year. The coding might change for that. How does that get put into the system? And in Alberta, you know, and probably like BC, right? There's constant emergency response. There's a fire, there's a flood, there's a tornado. There's something happening. There's earthquakes there. Not so much in Alberta, and no earthquakes, I don't think, in BC, but there's always an emergency that is tripping us up and you know, challenging us to think differently. Another way to look at that is just this way. You know, I won't get into it, but we break things down into break fix, continuous improvement, single intake components. This is our next layer of work. How do we make the system better? But it's going to challenge us because we're going to constantly also be morphing the system, redefining the way we document. We might use a flow sheet in one space and then decide, you know what, that's giving us coded data, but you know, that may move to maybe a progress note, right? So that is constantly challenging our data and analytics groups at the back end. Partnerships, we work with the Arch Collaborative, Class Global in Arch Collaborative is a group that have about 300 organizations that measure the user satisfaction of the system. We did a survey with them about maybe 2 years ago in January, coming up January. And we learned a lot. We learned that our clinicians aren't that satisfied. And they gave us some really great information. We scored 14.8 on the user scale, you know, 25th percentile out of 300 organizations, 3rd percentile out of all the Epic users, and 38th percentile around with organizations that are kind of very similar to Alberta. So this is challenging us. They told us we had too much documentation, too much duplication, all of our goals that we set. They said, no, you didn't meet them. And so, you know, we are relooking at things, but this is really valuable. It's going to shift the way the electronic health record works, right? These are some of our priorities: data accessibility, flow sheets and orders for nursing and allied health, training and clinical support, and enhancing the clinical voice and system governance. We really heard loud and clear that the clinicians wanted to help make the decisions on their electronic health records. It's not a digital health tool. It's not an IT tool. It's not a clinical informatics tool. It's their tool. And so that was actually some pretty exciting findings for us to show the passion around this work. Downtime, I think this one's my last slide for another consideration. Downtime is crazy. We had a system-wide network outage in Alberta Health Services maybe 9 months ago, you know, within the last year. All of our users, 100,000 employees, were locked out of the system for 4 or 5 hours. Something to think about, and the impacts this type of technology has to the data we receive, the way we use data, the way we document, the way systems make their orders. You know, we had to go back to paper, and we had to do that for 4 hours, and then we had to figure out how we backload that back into the system. One of the stats that we heard was an unplanned downtime cost the health system $500,000 for every hour for clinical recovery. And in an organization like HTIS, we have 120,000 employees trying to do that. They can understand, right? And that includes our ADT, our HIM, like everybody trying to figure out how to get that information that's been missed. So just some thoughts on that. You know, downtime is it's going to be a reality of our world with our cyber security challenges and everything. And so we really need to think about sophisticated business processes to support in an unplanned downtime. And really in AHS, it's a disaster. It was an absolute disaster. We learned a lot from it. So, and I think that is my last slide. And maybe I can stop there and we can talk questions and any, you know, answer anything that you might have.